certainly talked about with Project Inform before, and we don't see any, at the state level, see any reason why a plan can't contract outside of the county, and we continue to try to bring the plans and those out-of-county providers together. We've made, not huge, but we have made a little effort in that. I appreciate the advocates continuing to bring these issues to our attention. It's a large population being moved into a new form of care, and as Howard said earlier, bumps will occur, and the only way we can fix those bumps is if we know about them.
Thank you. I appreciate that, and I know you will be looking more deeply into some of the specific examples that were shared today. And we will move, at this point, our focus to the focus of this panel on the dual eligibles. And you'll start again, Ms. Ogle, and then we'll follow sequentially with our other witnesses. Thank you.
Thank you. So I'm very excited about this project. The CMS gave California, we were one of 15 states that received $1 million planning grant to look at ways that we can move dual eligible populations into organized systems of care. And so we have been working in a very intensive stakeholder process and working closely with CMS to identify what that project will look like. Just to define the population so we're clear, in this case, a dual eligible is somebody who is eligible for Medicare Part A, Part B, Part D, and for full scope Medi-Cal. So that is about 1.1 million people in California today. It's our belief, and it's CMS's belief, that most of these people, 75% of them, manage two very separate and distinct systems of care. They receive their Medicare benefits through fee-for-service Medicare, and they receive their Medicaid benefits through fee-for-service Medi-Cal. And the two do not meet, join, or in any way interact. We think that that puts a very vulnerable population in the ridiculous situation of having to be their own case management and care coordinators, and that there's a better and smarter way for them to receive care from people who know how to navigate these systems. We believe it results in a very fragmented system that results in a lot of very high utilization and a lot of duplication because one hand doesn't know what the other hand is doing. So, going back to the triple aims that I mentioned at the beginning of my testimony, this project, again, is focused on the triple aims of better health for people, higher quality health care, and reduced costs. The timeline for this demonstration is very aggressive, and this is both our timeline and the timeline that's come to us from CMS, so it's a joint timeline. Last spring, we released a request for information, and we had 39 responses that were very detailed and excellent responses to questions and concerns that were raised about duals. In August, on the 30th, we had a stakeholder meeting here in Sacramento, and we had over 300 people attend that stakeholder meeting, and we talked about specific areas of concern. Next week, last week and this week, or this week and next week, we'll be holding 3 stakeholder meetings. One was in Sacramento, the next one is in San Francisco, and the one following is in Los Angeles on specific issues, and I'll go into those in just a moment. Towards the end of this month, we will be releasing site selection criteria. The first round of site selection criteria will be broad, sort of checkbox things that any organization, in order to participate in this project, will have to have. And then in January, we'll go into more detailed of specific things that participants will have to have in terms of network adequacy, beneficiary protections, materials, due process. I'm not going to get them all off the top of my head, but all of the things that Medicare and Medi-Cal require for participation and delivery of services to beneficiaries.
If I might interrupt, so your reference to the selection process, that's because this isn't being implemented statewide. It's being implemented based on certain pilot projects that are selected. Is that
Sorry,
correct?
I should have said that to begin with. Yes. So AB 208 allows us to implement in up to 4 counties and using at least 2 different models, a 2-plan model and a county organized health system model. Other than that, it's not very specific, but those are sort of some broad parameters within which we're trying to look at this.
Thank you.
As I said, we are involved heavily in a stakeholder process, and I'm at the risk of getting whacked. I'm going to brag a little bit. CMS has told other states that they should look at the stakeholder process that we're doing here in California because it's so comprehensive. So we have, let me just keep going here. We have 4 work groups basically based on that look at key policy issues. There's a behavioral health. Let me step back for a minute and say, as you all know, there are organizations called Medicare Advantage special needs plans that exist today in the state that serve about 160,000 people. That combines Medicare and Medi-Cal services. It does not include behavioral health services that are Medi-Cal benefits, nor does it include long-term services other than the Medicare and limited Medi-Cal benefit. CMS has been clear, and we've been clear, that this dual project needs to expand that and include the long-term systems and supports and behavioral health so that a person has full range of services available to them. So to make sure that we have a clear understanding of that, we have 3 work groups going on. One in behavioral health, and we're working with stakeholders there to understand how we can either coordinate with the future of possibly integrating behavioral health so that a person has their Medicare behavioral health benefit that is primary physician and psychologist, and their Medi-Cal benefit that is more treatment-oriented and more social components to it. The second group is the long-term care coordination group, and with that we are looking at how do we integrate IHSS services, in personal care services, the new community-based adult services that you used to know as ADHD services, and SNF into a managed care plan so that the plan is responsible for the entire continuum of care. The third group that's meeting on the 12th in San Francisco is the Consumer Protection Group, and that's where we're looking at what does enrollment look like, who's eligible, what does eligibility mean. We certainly are looking at passive enrollment with an opt-out as a way to give the plans enough membership so that the risk is mitigated and they can move forward. As you know, right now, Medicare enrollees are done on a one-by-one basis. Each one is a sale, and we believe that that may not be the best use of our limited finances to make this project work. So a passive enrollment with an opt-out that people can go back to fee-for-service Medicare is something that we're looking at and something that CMS has encouraged us to consider. The fourth group that is an internal group is the financial modeling group, and we're working directly with CMS, and their actuaries are talking to our actuaries about what the financial model will look like, because ultimately the financial model will be a contract that has a blended rate from CMS, the state, to a provider plan group. We're looking primarily at the capitated model in California right now. That CMS offered 2 models, a fee-for-service model and a capitated model, and we are looking primarily at the moment at the capitated model, but we did leave open the option of looking at the fee-for-service model going forward. We understand that the savings in this program will primarily accrue to Medicare in the first years because we believe that the savings will be in the inpatient part of the care delivery system, and Medicare has already made it clear that they are going to be sharing in those savings in the first year so that it's worth everybody's while to do it in the first year and we don't have to wait a long time for savings. We will continue through the site selection process in the spring. We're looking to a contract in June to develop materials through the summer so that beneficiaries start to be noticed in October for a start date of January of 2013. And right now we are talking about a rolling enrollment as we used in the SPD program so that we don't move everybody into plans on day one. We realize that there are certain plans in the state that already care for the seniors, for the dual eligible population, the PACE and the SCAN programs, and we are talking with CMS about ways to make sure that those people can continue to receive services in the plans that they've chosen. I'm just trying to make sure that I get through everything. We are developing an evaluation framework. CMS has identified an evaluation partner, RTI, that we'll be working with to create a framework that looks not only at the process measures that HEDIS reveals to us, but also outcome measures so that we know if we've reduced hospitalizations, if we've reduced inappropriate ER use, if we have improved the health outcome for this population. So I'm talking really fast. I'm sorry. It's a very large program. We've worked very hard with stakeholders to make sure that everybody's aware of what's going on, and we'll continue to do that as we move through this process. Thank you.
Thank you very much. We will move to our next panelist now. If you'd introduce yourself, and we will open to questions after the panel completes their testimony. Thanks.
Thank you. I'm Kevin Prindeville. I'm the Deputy Director of the National Senior Citizens Law Center. I want to thank the chairman and members and staff for holding today's hearing and for having us here. I'd like to do 4 things with my time: tell you a little bit about my organization and our work on this issue, explain what we see as the similarities and distinctions between the dual eligibles pilots and the enrollment of SPDs into managed care, describe some of the concerns we have about the duals project, and in those concerns provide some recommendations for your committees. The National Senior Citizens Law Center is a national nonprofit organization committed to protecting the rights of low-income seniors. We were founded in California, and we maintain strong advocacy efforts both nationally and in California. And our work on duals issues is a reflection of that. So in California, we've been very involved with the Department of Health Care Services. We served on the 1115 stakeholder subcommittee on duals issues. We served on the dual eligible technical assistance panel, and we've been engaged currently. Nationally, we were funded by the SCAN Foundation to write a series of papers on issues impacting dual eligibles with the audience of state policymakers and federal policymakers. The first of those papers is one that we hope to get in front of the committees, is about ensuring consumer protections in models that integrate care for duals. We also are in frequent communication with CMS about these issues, and we're currently leading a work group of advocates from the other 15 states that are pursuing a path like California's. So through our work, we've come to the conclusion that we currently are very supportive of the goals of the dual eligible integration pilots. Care for duals can and should be improved. And if they're designed and implemented with the person at the center and not the insurance industry at the center, as was talked about earlier today, new models for serving duals will provide or can provide the promise to improve care, decrease hospitalizations, increase access to home and community-based services, and potentially, over the long term, slow the cost curve in the health system. But if the implementation is driven by cost savings and projected budget numbers and administrative efficiencies as the primary goal, the risk created by these models is significant. We could create new barriers to care. We could create financial incentives that limit care instead of providing care that is needed by this population. This is a sick population. It's a population with high health needs. There's no way around that. So if the focus is just on savings, the results can be disastrous. So to ensure that the focus stays on the people, there needs to be strong consumer protections within the models that the department pursues. We've written extensively about consumer protections, both in our public papers and also in the comments that we've submitted to the department throughout the stakeholder process. I'm going to go over a couple of those very briefly. The first is choice. We think that it's essential that in these models, enrollees and potential enrollees maintain the right to choose whether to join. For us, that means starting with a voluntary opt-in enrollment, not an opt-out enrollment. We also believe once a person is enrolled in the model that they need to maintain the right to choose which providers they see. In the context of this population, it's very important, since we're talking about the integration of long-term supports and services, they also maintain the right to manage their own care, an important principle of the IHSS program. Moving beyond choice, beneficiaries need to maintain access to both Medicare and Medicaid benefits, that where the two systems conflict, the individual should be entitled to the better of both worlds. In that regards, with regards to benefits, consumer protections, appeal rights, and also current services. It's essential that as people transition into new models that they maintain the services that they have today, that they don't lose access to services as they transition. We think it's essential that there be an effort to increase access to home and community-based services. And as another consumer protection, maintaining access to current Medicare and Medi-Cal providers. There's lots of talk about the fact that these individuals aren't in what we call organized systems of care, but that doesn't mean that they haven't created an organized system of care for themselves. Many dual eligibles are very savvy individuals or have family members that have helped them create a network that does work for them. As they transition into new systems of care, there need to be ways for them to maintain access to the networks they've built up for themselves throughout their lifetimes. It's different than an uninsured population, for example, in that regard. These are folks that are using the healthcare system. So with that's just very briefly some ideas about consumer protections. I want to talk about the distinctions that we see between the duals pilot and the SPD enrollments. While both projects deal with a similar population and share a goal of moving the population into a more organized system of care, the duals pilots represent a much more complicated and difficult task involving several pieces of our health system that the SPD enrollment does not begin to address. The goal of the duals pilot, as Jane mentioned, is to integrate all Medicare and Medi-Cal financing and benefits, which includes primary care, acute care, long-term supports and services, and behavioral health. It's an ambitious goal which the SPD process has chose not to take on and hasn't attempted to take on. The SPD process does not, for example, begin the difficult task of integrating Medicare and Medicaid program rules, coverage standards, and financing. The principal difference between a dual eligible and an SPD is that a dual also has that Medicare coverage. Medicare is covering the majority of primary care and hospitalization costs for duals. In the integrated programs, it's essential that duals not lose access to those benefits or the people that are providing those benefits. The SPD process only takes minimal steps to begin the integration of behavioral health services. And then finally, and most importantly, the SPD process does not begin to integrate long-term supports and services, other than perhaps through increased care coordination. In two plan counties, in two plan counties, long-term institutional care remains a limited responsibility of plans. They have no responsibility for IHSS, ADHC, MSSP, and other home and community-based services. So whatever we're learning from the SPD process isn't teaching us much about integrating LTSS. And that really is the most difficult thing that we have to deal with here. And it's about blending a medical approach to caring for individuals with an approach that also takes into account someone's social needs, which is something that California is the national leader by a mile in figuring out in terms of its ability to allow a lot of people to self-direct their own care and to establish for themselves care goals. Other states have done a lot of work to figure out how to integrate that with other health services, and we should be looking to those states as models. But all of the issues that we talked about today on SPDs are just going to be that much more difficult in the duals process. Enrollment is going to be more complicated because you're also dealing with the Medicare side of the individual's care. Provider networks and continuity of care issues are more complex because you're dealing with the Medicare side, plus you're dealing with networks that have been built around behavioral health services and long-term services and supports. Assessments are more difficult and will need to be more comprehensive because, again, we're trying to do in the integrated pilots an integrated approach that includes the LTSS and behavioral health. And finally, beneficiary communication is going to be much more difficult. The enrollment packet that Ms. Ogle held up earlier today could easily be 5 times as long once you've added information about Medicare, LTSS, and behavioral health services. Wisconsin, one of the innovators and leaders in doing integrated care for duals, has a 76-page manual just to describe the appeals process for people in their integrated system. 76 pages just for appeals, and they're held out as the model. So we have a long way to go. So some of our concerns and recommendations at a very high level, hopefully there will be time over the next several months and years to work with you on the specifics, but one of our main concerns is scope and size. We believe it's essential that these pilots be treated as pilots. Hopefully what I've just outlined as the challenge in front of us will convince you of the same. But they need to start relatively small, with small populations in defined geographic areas, done by selected plans that have a proven track record and progress towards the goals here. We do not believe that it would be appropriate to use the entire county of Los Angeles with something like 350,000 duals as a pilot site. That's more duals than any of the other 15 states that are headed down this road will tackle in their entire state, not to mention in their pilot. We do not think that that's appropriate. We also are concerned with an approach which would bring too many plans into the pilot at once. We think it's best to start with a small, hand-picked group of plans that have a demonstrated commitment to these issues. We're also advocating for a phased approach to the integration of services itself. We don't think it's a good idea on day one to give all risk and all authority for all of these different components to one entity, but rather phase in risk, phase in authority and accountability over time. And the department has actually put together some potential ideas for how to do that. And so our recommendation in this area for the legislature is to not provide any expanded authority to DHCS beyond the current 4 pilot counties. I'll just make 2 more quick remarks since my time is up. But the second is the next is state capacity. We're concerned that the state does not have the resources to do anything larger than what it has already imagined. And finally, just the legislature pay very close attention to the financial incentives that are created by these models.
Thank you. Thanks for abbreviating your final comments there. It's appreciated. Next witness.
Good afternoon, Mr. Chair and members of the committee. My name is Margaret Tater. I work at Cal Optima. I'm the Executive Director of Public Affairs. Thank you very much for this opportunity to speak to you this afternoon about this issue, given its importance and significance not only to our local community, our plan, and the members we serve, but everybody in the state. I just wanted to touch on 2 themes this afternoon and then, of course, open it up to questions as soon as possible. 2 themes. Number 1, a brief background and a brief overview of the county organized health system model, because it is there are some distinctions that I think are worth noting as you continue to consider oversight issues for these dual pilots. And then similarly to Kevin's comments, I think it would be helpful to talk a little bit about some general observations of issues that we see as critical for purposes of developing these dual pilots. So the county organized health system model is a model that exists in 12 counties in the state of California. There are 6 county organized system plans. Cal Optima is the largest of those county organized health system plans. We serve the beneficiaries in Orange County. By the numbers, we serve about 420,000 members. Of that number of our overall membership, just by way of background, about 110,000 are seniors and persons with disabilities, about 70,000 are dually eligible members. A distinction in connection with the county organized health system model is the fact that the county organized health system, the COES model, has the population, the entire Medi-Cal population, mandatorily enrolled. That includes the 100,000 SBD members I talked about and the 70,000 duals that we take care of. By way of clarification, however, we take care of those 70,000 duals for their Medi-Cal benefits only. So given the fact that we have the entire population and we have substantially all of the acute and physical Medi-Cal services in our plan with a few number of carve-outs, we've had a longstanding commitment as COES to really enhancing the coordination of services across the continuum. So it's not atypical for county organized health system plans to offer some of the home and community-based services. For instance, Cal Optima is an MSSP provider for our local community. 3 of the county organized health system plans several years ago, when the Medicare special needs plan opportunities became available, became Medicare SNP plans in their communities. So Cal Optima, the health plan of San Mateo, and the Partnership Health Plan all offer special needs plans in their counties, in their communities. Again, reflective of the fact that the county organized health system has a history of aiming for ever coordinated, integrated systems of care for the populations that we serve. By way of background, then, we are here today because we have been following and working with the state in connection with the opportunities set forth in SB 208 as well. We've served on various work groups and some of the waiver subcommittees. We're very happy to be participating in the stakeholder process that Jane identified and outlined at the outset. If our board and if our local community and if the state were to select our county organized health system model as one of the duals pilots, I mean, we would be very happy to participate and very happy to be a part of this. By way of recommendations and overviews and things to think about, certainly, from our perspective, we can't underestimate the importance of public vetting and public processing. Certainly, when the state publishes and gives us more detail on the site selection process, we will be embarking on a very extensive stakeholder process at the local level. I would imagine that any of the participating plans that would be interested in being pilot programs would need to do the same. The stakeholder process and the vetting process is critical. It's critical not only for the members, it's critical for the providers to understand what the requirements of this new pilot system would be. How would it work? What would it look like? How would we develop the contracted networks for it? CalOptima in particular, teeing off a comment from Kevin, we have had a long-standing commitment to viewing the incorporation and the inclusion of home and community-based services in our menu of services as an important first step. To that end, we've been working, of course, with our local ADHC community this past summer, and we will continue to work with the local ADHC community as we transition ADHC into the new benefit, the CBAS benefit, and then ultimately include that in the managed care context. To a degree, that exercise of working with the local community, getting clarity around the benefit, getting clarity around the standards for how it will be included in our plan, how we will manage that benefit at some point, has been an interesting exercise for purposes of what you really need to do. There needs to be a lot of processing. We've been working very closely with that ADHC community to review the assessments and understand the members' needs and make sure there's no disruption in care for this incredibly vulnerable and fragile population. So we view not only general public processing and general stakeholder input to be critical, but we also do believe that an initial focus would be helpful to be on the coordination, integration, if you will, of the home and community-based supports. It's a little different in the county organized health system model because the COs have the residential benefit, the room and board, the long-term care facility benefit in our plans. So, for example, in CalOptima's case, we have contracts with over 80 of the long-term care facilities in our county. The facilities and the provider network is not unknown to us, so we would look forward to, again, enhancing our networks on the home and community-based side, working collaboratively with the IHSS program at the local level to begin the incremental process of working more collaboratively with that program as well. So with that, and in the interest of time, I will leave it open for questions later. Thank
Great.
you.
And you will have an opportunity in the Q&A if you want to add anything that you didn't. I am going to deviate from our proposed course of action here. Our colleague, Mr. Nastandi, has to leave to catch a plane and wanted to pose a question before his departure. So, Dr. Luxenberg, if it's all right, we'll get to you in just a moment, but we're going to afford this opportunity to our colleague, Mr. Nastandi.
Thank you, Mr. Chairman, and my apologies, Dr. Luxenberg, and thank you for allowing me to jump in really quick. Ms. Ogle, on the process of going out to bid in the pilot projects and so forth, I hope there's going to be a thought of innovation in this process, doing something different, and basically moving towards what the federal policy is, what the federal legislation is, which is in many cases, allowing the government to contract directly with medical groups as opposed to just contracting with the plans. Are you open to those type of that process?
Right, I'll be honest with you right now. At this point, we are looking to work with our existing plan partners, and we understand that most of those plan partners have subcontracts with medical groups, and that is a way for medical groups and IPAs and others to participate in this. As you know, bandwidth is an issue in the department, and we want to be sure that we're doing this correctly. So just as we probably aren't looking at large national organizations coming in to take on this population, we're looking to.
It doesn't have to be a large national operation. It could certainly be a California-based operation. And some of these groups are already, the ACOs are doing this, right? That's what they do, and that's what I think President Obama wants to move towards, coordinating this care. And I would think it would be at least a good idea to try some of that in our implementation, since we're moving towards that anyways as a national policy.
And I'll be honest with you, we have had limited conversations with CMS about how the ACOs will work in relationship to these dual pilots, and we haven't gotten total clarity on that yet. They could be working in parallel. I just don't know.
Well, all I'm asking is hopefully that,
sure.
I heard what you said, I appreciate it, but hopefully I'm just asking if we can maybe allow the process to be a little more open and try not just stick with the process we have, but I think the medical groups are in some areas capable of doing this, possibly for a lower cost, and I would just ask that we at least entertain that thought.
Thank you.
And I
Will
appreciate
do.
And Mr. Chairman, thank you so much for allowing me that time.
Thank you, and we appreciate your presence and participation here today. Have safe travels. And we'll move now to Dr. Luxembourg, presenting on behalf of the PACE program.
My name is Jay Luxembourg. I'm a primary care geriatrician and the chief medical officer of ONLOC, which is a program for all-inclusive care for the elderly, or PACE, as it's been alluded to. Chairs and members of the Senate and Assembly Health Committee, I thank you for the opportunity to testify before you as you consider the department's implementation of this dual-eligible pilot program. We are existing providers of managed care that integrates the Medicare and Medi-Cal benefits for this population. And we've been advocates for truly managed care for a very long time, and we fully support the goals of the dual-eligible pilots. But based on our extensive experience and expertise in serving the very, very frailest of this population, we believe that we have a lot to offer to help the state achieve the dual goals of improving care and saving money. ONLOC was a grassroots effort from the California community to address the needs of the very frail elderly who would be in nursing homes. And having come from the nursing home world for 25 years, it's very refreshing to be in an environment where that's the enemy, that's the failure of the system, and our goal is to keep people in the community. And we do that by integrating the medical, the behavioral health, and the long-term care services that are the goal of this dual-eligible pilot. But ONLOC, after this model was proven to be both efficacious for quality and to save money, became the template by which this has been replicated around the country as the PACE. And now here in California, CalPACE represents the 5 operational PACE programs and 2 PACE programs that are expected to be operational in 2012, one operated by the Los Angeles Jewish Home and the other by Cal Optima. And in addition, 8 other organizations have filed letters of intent, and several have filed applications to become PACE programs. So this is a currently expanding model with demonstrated success. So I'm just going to remind you that this is, in essence, a carve-out, a program that provides a benefit for people that the state has determined were eligible to be in a nursing home and that they're over the age of 55. Almost everyone we serve is a dual eligible, although we do serve some people who don't have the Medicare benefit. We provide all of the mandated Medicare and Medi-Cal covered benefits, primary care, specialty care, behavioral health care, adult day health care, in-home services, prescription drugs, lab and diagnostic services, all the therapies, transportation, and, if necessary, hospitals and convalescent level nursing home care. So the full spectrum, integrating all of these payer sources. And doing that, we're at risk and have been at risk since the beginning of the PACE programs, under capitated payments that don't change even when people transition into more expensive care environments like nursing homes. How do we do that? We do that by prevention and keeping people out of nursing homes. If people go into nursing homes, we lose. So we provide services that are not covered benefits by either the Medicare or the Medicaid program, including bed bug elimination, home cleaning, physical improvements to the home to allow people to be safe in the home, air conditioners, functional refrigerators, grab rails, ramps, whatever it takes, using tremendous creativity to keep people in as home-like an environment as possible. And collectively, the 5 Cal PACE programs have more than 80 years of experience doing this integrated care to these very frail people. And in essence, what we are doing is providing end-of-life care. It's extraordinarily uncommon for people who are eligible to be in a nursing home to sort of get so well that they're no longer eligible. Really, we're providing care for people in the last 3 to 5 years of their life. So we do serve the frailest of the dual eligible spectrum. Certainly, according to data compiled by DHCS, over half of these dual eligible people have 4 or fewer chronic conditions. And at the extreme, 30% of the dual eligibles have 10 or more chronic conditions. Well, PACE provides people who average 14 chronic conditions, average age of 79, impairment in at least 3 activities of daily living like bathing and toileting and feeding. 2 out of 3 of the PACE participants have some form of dementia. And basically, our belief is that for this very, very frail population, simply enrolling them in a managed care environment puts them at a tremendous risk. We feel that PACE is a proven model of care and deserves a chance not only to remain a benefit for people during this transition period, but to remain a viable option available to people on an ongoing basis that meet these very, very stringent criteria for frailness and nursing home eligibility. We already know that PACE reduces hospital stays, reduces nursing home usage. That track record of research confirmation of cost effectiveness is something that's very uncommon in the type of managed care world that we're talking about. And keeping that as an available choice, we believe is really an appropriate goal. We feel that most managed care plans don't have the experience or the expertise to meet the managed care needs of this very, very frail population. In fact, many of the managed care plans have communicated with PACE. They'd prefer them to go to PACE. But based on the experience that we've heard this afternoon about the transition for seniors and persons with disability, if not properly implemented, it's easy to envision how a opt-out phenomena could potentially cause breakage of care that would end up precipitating nursing home placement. And my own experience, and I know the PACE experience in general, has been once people are in nursing homes, it's much more difficult and darn close to impossible to reverse course. And so we want to make sure that the coordinated care that PACE offers doesn't get offered right when people are on the verge of nursing home placement, or perhaps once they're placed in nursing homes, but remains as now an option for people that are at risk. And so we have some suggestions. We ask that the dual eligibles be assessed as part of the enrollment process for their eligibility for PACE in counties or geographic areas that have PACE programs. We want to provide those that appear to be eligible an option to enroll in PACE at the point of initial enrollment, again, rather than as an opt-out phenomena. We want to make sure that PACE is mentioned as an enrollment option in the enrollment materials and the enrollment assistant programs that are going to be presented as part of the implementation of the dual program. We'd like to require managed care plans to assess and identify dual eligibles who are enrolled in their plans who may be eligible for PACE and provide them an opportunity and the information that they need to make a valid choice to enroll in PACE. We believe that these measures are consistent with the intent of SB 208, Steinberg, which states that persons meeting the requirements for PACE may select a PACE plan if one is available in their county. These measures were not included in the transition to mandatory managed care for seniors and persons with disability under the 1115 waiver. As a result, many have had to disenroll from the plans they were enrolled in or have spent 60 days in nursing homes and then gone back to fee-for-service Medi-Cal. And we know at that point, even with the tools of PACE, many of those can no longer be cared for in the community. And so we really do believe to facilitate choice and to provide a meaningful evaluation of outcomes under the pilots that the plans participating in the pilots should be responsible for providing all of the Medicare and Medi-Cal covered services and be at risk not only for the short term but the extended nursing home stays like PACE is. So again, in the interest of time, I will...
Well, thank you very much, Doctor, and all members of this panel. We will open to questions. I just wanted to ask on your testimony in particular, you commented that through the PACE program you're able to provide certain in-home improvements, ramps, refrigerators, air conditioners that aren't covered. How are those paid for under the PACE program?
Remember that PACE is entirely capitated. It's combining the two flows of money, the federal money and the state money, and then really we're held to, at a minimum, provide what Medicare and Medi-Cal provide, but anything else we want to provide that allow a person to stay in the home environment, we're allowed to do. And that creativity, that letting the money follow the person's needs is just so logical. I have to say, as a medical student, I was exposed to Onlock. And then, as a geriatrician in training, I went to England for an extended period of time watching their geriatrics program under a national health program. And there, they were able to actually install indoor plumbing for elderly people that had outdoor privies, I believe is the term, and that was what they needed to stay out of a nursing home. Because of their logical and national health system, they were able to redirect funds to put in handrails, put in indoor plumbing, heating, whatever was necessary to allow somebody to stay in the community. And it saved money.
How many counties in California are there currently PACE programs?
There's 5 PACE programs. Our PACE program serves 3 counties, and I can't answer the question of how many counties. I can't speak for the other programs.
Okay, thank you. I heard a comment up to perhaps 18 counties. A question for Ms. Ogle related again to some of the questions. If somebody's currently a beneficiary of a PACE program and it ends up being one of the pilot counties for the dual eligible transition, will they be allowed to stay in that PACE program if they're already being served by it?
It's our intent not to disturb their membership in that program. So it's certainly our intent not to have somebody be defaulted into a plan to have to move back into PACE. So the intent is to carve those people out and leave them in their PACE program rather than involving them in any of the pilot programs, yes.
And can there be any lessons learned from the PACE efficiencies and success in terms of the objective of keeping elders in a home setting? Will that inform how the dual eligible program is structured?
Well, certainly, as I talked about the long-term services and supports being part of what the plans will be required to provide, just as in the PACE program, it would be beneficial to both the member and the plan to be at the least expensive level of care. I'm not finding my words very well right now, but what a plan would be incentivized to do what it could to keep somebody in the home. And personally, I worked at a special needs plan prior to coming here, and we had circumstances there where we put in ramps, we bought refrigerators because that allowed people to stay in their homes. And I think special needs plans in general recognize that that's an important component, even without the long-term care that will be part of this.
And is it fair to are in-home support services critical to this implementation?
Absolutely, thank you.
Yeah.
So in-home and the coordination of in-home support services, I think, as I probably didn't say, we recognize that in-home support services have a primary tenet that the beneficiary gets to select and control who provides that service to them. And none of the things that we're talking about would disturb that primary tenet that the beneficiary is in control. And frankly, the beneficiary should be controlled throughout their care, picking their providers and picking, being able to manage as much of their care as they possibly can, with the assistance of the plans that have some understanding of what the care delivery system is in their neighborhood. In-home support services offer a wonderful opportunity, if the beneficiary allows, for the plan to understand what's happening in the home and make sure that there are sufficient services in the home so that the beneficiary isn't moved to a higher level of care.
Thank you. And I know Ms. Atkins has a question.
Well, thank you. A question of the chairs, but a few comments first. I didn't comment during the earlier panels because I thought that was feedback and comments related to the hearing today, in particular some of the hearing objectives and goals outlined in your materials you gave us in advance. Well, one question actually to follow along with your PACE question, Mr. Monning. Dr. Luxemburg asked or made a comment about initial enrollment as an option in enrollment materials, including information about PACE. Will that be part of whatever?
That's something we're going to very strongly attempt to do, yes. We want people to know that PACE is an option.
Okay, thank you. And, I congratulate you. The PACE program, we have it at some areas in San Diego, and it's a really incredible program. And it gets back sort of to what I think Mr. Prindiville made a comment about blending medical and social needs, which is the hardest part, and I think you said that. The comments I want to make, I really want to thank the chairs for pulling this hearing together. I cannot thank you enough. This is so important. I got a lot of valuable information today. I will say, however, a few minutes into this last panel, I could hardly really focus and pay attention because I'm very concerned about what I heard in panel 3 and panel 4 that I don't think we really could take time to delve into, and I'm a little concerned about that. I understand, as you put, Ms. Ogle, this is a huge endeavor. It's sort of like turning the Titanic, I'm sure, But one of the main goals you outlined here, or objectives, was to basically inform the public, but also fulfill our legislative oversight role with regard to how this proceeds. So I hope that we will continue to do that, and I will certainly make myself available. And as one of the last people standing, I think it's really important, which is why I thank you so much. But I'm very concerned about not getting some of the comments or responses to some of the concerns, because also under the objectives you talked about feedback in order to make recommendations for how to proceed forward and the planning process and the preparation for future implementation, and certainly to identify strategies that can be replicated for the exchange in DHCS. So to learn lessons learned, how to avoid or what to do differently. And so all of the speakers I really appreciate. I know some of them, it seems, had to leave from the earlier panels, but I just wanted to comment on that and say this has been valuable, but only so much if we continue to do the oversight role. And so I hope that we will get some comments back on some of the things we heard earlier, because I think that's a critical piece of oversight. Thank you.
Thank you, Ms. Atkins. And if there are no further questions, we are going to move to just kind of wrapping up. I want to afford Dr. Hernandez an opportunity. I do have a point of information clarified by staff that PACE is currently in 7 counties at 18 different sites in those 7 counties. So I think it would be valuable in criteria for the selection process that be factored in with site selection, if not for all counties, at least to make sure that's part of the pilot experiment in selection. Also, in response to Ms. Atkins' comments, testimony from today will be posted on our committee website. We'll also welcome submission of written testimony and any other follow-up, either people who provided testimony or other stakeholders would like to share with us. And it is the intent and the mission of both of our committees to provide ongoing oversight of the implementation process. I do want to thank the department and the stakeholders for what is clearly a commitment to try to make this work. And I think if there's any takeaway from me today, it was echoed by a number of witnesses. We need to look at this through the lens of the patient and not have our timetable be based on numbers count, but rather the protection of patient security, health, and safe transition. So I know that's a principle that nobody will disagree with, but I just want to underscore that as part of our oversight is making sure that we minimize the bumps in the road to as small as possible, affecting as few as people possible, and if necessary, have the timetable be determined by patient need in successful transition. So with that, I just want to thank all of you, and I'll give the last word to Dr. Hernandez and thank him and his staff in preparation for today's hearing, and again to thank all of you. Thank you.
Thank you very much, Chairman Manning, for the opportunity to make a few brief comments before we move on to public comment. Let me take this opportunity to also thank everyone who presented today, the department, as well as the stakeholders. And I also want to echo some of my concerns that were expressed by Assemblymember Atkins with regard to some of the comments and questions on panels, I believe the middle 2 panels as well. And let me just reiterate what Assemblymember Manning said, that this, obviously, we're going to continue on to make sure that we address and look at the needs and what we're going to be doing throughout the year as well. I mean, there's a couple takeaways that, that I've heard that we need for consistent policy and practices on continuity, but more importantly with the MERS and the need for greater affirmative selection to plans as part of the healthcare options process. So I'd like to hear back from many of the individuals here today in the coming months so that we can make sure that we can address these concerns, work with the department to make sure that they're addressed, especially with regard to the MERS and the continuity of care. So with that, I'd like to just close by thanking everyone for being here this afternoon. And at this time, we'd like to open up to public comment. There's a microphone here that we could, if you can just state your name, just your position, and some of the comments you may have. Thank you very much.
Mr. Chairman, Elizabeth Landsberg with the Western Center on Law and Poverty, and I want to thank you for having this hearing and for your staff for doing so much work to put it together. We were involved back with SB 208 and AB 342, and I think we all tried to put some careful protections in place for consumers, and they just haven't all come to fruition. I appreciated Ms. Ogle saying that she recognizes that there have been some systemic problems and that the department does plan to address them. All of the issues that Ms. Murphy and Ms. Donnelly raised today are issues that a work group of consumer advocates who have organized ourselves have been working to raise with the department over several months. So we appreciate that the department, that this is challenging, but this was a timeline set by this department and frankly by this legislature, and so this oversight is critical, but it's time to make some changes. We've been talking about problems with the MERS, we've been talking about problems with healthcare options giving out flat wrong information. The Medi-Cal Managed Care Ombudsman gives very good information and help when you get through to them. They're woefully understaffed. And so we appreciate that both of the chairmen here today are talking about wanting to have continued engagement, and we hope that there will be specific reports back from the department to the legislature to make sure that we finally address some of these issues. And we would echo the comments made by Assemblywoman Atkins that we truly do need to learn from the mistakes of the SPD transition. We've frankly done it a little too fast, and we've rushed into it, and we hope we won't make the same mistake with the duals, who are a very similar but in some ways more vulnerable and more complicated population. Thank you.
Deborah Doctor from Disability Rights California. I'd like to associate us with the comments that Elizabeth made and also Kevin made. I'm very concerned about the Duals project and making sure that the bumps in the road aren't the bodies of people who didn't get care. On the subject of the pilots, we've not gotten a clear commitment from this administration that they're going to stick to 4 pilots, and if LA is a pilot, I mean, that's not a pilot. It's the whole plane. It's a 747. So we're very concerned that it would be hard to turn those kinds of pilots. It's not clear to us what is being tested. If these are really pilots and not just phase 1, what is being tested? Are there going to be 4 different approaches that are being tested and lessons from those? There are other models that haven't been mentioned, such as cash and counseling model, which has been used in other states for many, many years. I want to make a comment about the stakeholder process. I'm one of the stakeholders, and it's true that I've been invited to and go to a lot of meetings. But the voice that has been almost completely absent from the stakeholder process is the voice of people who are actually going to be affected. There have been virtually no dual eligibles at the huge meeting in August, which we've come to call the speed dating meeting, where the plans got to talk about their attributes for 10 minutes each. There is going to be one big meeting in San Francisco on the topic of communication protections for consumers, and one meeting in Los Angeles on long-term care. It is just not realistic to expect the people who are affected, who live in Northern California or in the middle of the state or in the southern part, to go to LA to have one and only chance to talk about this. I think there's probably 50 people, if that, in the state who are dual eligibles who even know about this process. I have been urging DHCS and its contractors to reach out more, to give more opportunities. I know they had a listening session in Berkeley and one dual eligible person showed up, so that suggests that maybe there's something to be learned there. And for it to be a real stakeholder process of which the state and CMS could be proud, it should involve the people who are going to be affected, which is not me. Another concern that I have is it has to be okay for managed care plans to say, we're not ready. We are not ready to be one of the 4 pilots. That has to be an okay choice for them to be able to say, we don't have the capacity, we don't have the connections, we don't have the expertise, we don't know anything about IHSS, we don't know anything about functional assessments. We'd like to see what's learned in the pilots and then emulate the best. That's something that we didn't do in the SPD transition, and I think we should do. So, again, we have many, many, many concerns and appreciate the opportunity today to express them. Thank you.
Mr. Chairman and members, my name is Scott Pfeiffer with Age Tech California, and my comments apply to both programs, the SPD transition as well as the dual eligible projects. And in the interest of innovation, we think both of these programs provide an opportunity to do things a little bit differently, maybe a little bit smarter than we have in the past, and use available technology tools such as telehealth. We recommend the use of point-of-care technologies to improve care coordination and streamline communication with providers and consumers to have a greater connection for consumers to providers, and the use of telehealth-enabled care management. And telehealth-enabled chronic care management really can help achieve the aims of prevention and care staff efficiency. And home telehealth tools really also empower consumers to have greater self-health management and independence, and in the goal of helping to keep people independent in their homes as they age in particular, as well as resulting in cost savings. There's mounting evidence, research from CMS telehealth demonstrations using chronic care management tools that result in significant cost savings, particularly in the area of long-term care and avoiding unnecessary institutional-based care versus home-based care. So lastly, in particular, we recommend in the dual eligible project that in the site selection criteria that there be incentives of some sort or factors given to planning to use available technologies such as telehealth in serving these populations. So just a point for consideration. Thank you.
Good afternoon. My name is Lynn Kersey. I'm with Maternal and Child Health Access in Los Angeles, and I too want to thank the panel, the Assembly and Senate Health Committees, for being here today and for staying so long to listen to the testimony. You might wonder what maternal and child health has to do with seniors and people with disabilities, but women actually are disabled sometimes, and children are disabled, and we also serve the families and anyone else who needs assistance. And by the way, women who are disabled have a very hard time finding a gynecologist, obstetrician when they get pregnant. So that's one criteria that you might want to look at for dual eligibles. Are there enough obstetricians in the networks as well? It was mentioned that we need to get the choice rates up in order to succeed with the dual eligible project, and I would just beg that we not start talking about the next thing. And so this is already through. We have not finished with the seniors and people with disabilities, and I would hope that we could implement some of the suggestions and improvements that we talked about today in the process that remains in the next few months for the seniors and people with disabilities. I worked very long and hard in the 90s on the transition for families and children into managed care, and it took many, many years. Granted, that was a much larger population, but we had starts and stops, which in a different era with 70% default would happen today. There would not be continuance of this program if it happened in the 90s. So let's get the providers and the plans together first. Let's not use the patients as the carrot between the two. Make sure those networks are in place, because that's actually what's happened with the patients not really knowing what's going on. And I would say that much of the increase in the ER admissions in Los Angeles that have been written about and in other places has to do with people not being able to get their medications as seniors and people with disabilities. Even when continuity of care is approved, in cases that I have seen, it doesn't mean that the plan approves all the pieces of a person's care. With a woman who was diabetic, hypertensive, needed a very high-risk ultrasound, she was told to go to another radiology lab miles away, not available on public transportation, and we had to fight like heck to get her back to the radiology lab where she had been seen. So it doesn't always work even when continuity of care, so look beyond the granting of just the continuity of care. I would ask that in this transition period, that we approve and look to plans to approve whatever is needed in the process for the patients. And that's not happening. It's supposed to be happening, but it's not. Thank you very much for being here.
Thank you very much. Seeing no further public comment, I'd like to thank my counterpart in the Assembly, Assemblymember Manning, for helping me put this together. And so at this time, we would like to just adjourn the meeting. Thank everyone for being here.